Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. Today we continue our hashtag We Have MS series for 2018 with guest Dr. Norah Baker. Dr. Baker is a family practice specialist who is herself living with secondary progressive MS. She attended and graduated from Southern Illinois University School of Medicine in 2011, having over 7 years of diverse experience, especially in family practice. Dr. Baker recently stepped down from full-time patient care. Welcome, Dr. Baker.
Thank you for having me.
Oh, it's a pleasure. Now, can you share your MS diagnosis story with our listeners?
Oh, absolutely. I was diagnosed March of 2001, so I'm coming up on my 17-year anniversary at the ripe age of 21. I had just started college. I was an art major at the time, and it took probably 4 to 6 months before I got a definitive diagnosis. I had started with some vision loss and headaches, which then progressed to first through right-sided numbness and weakness, upper and lower extremity, and then progressed to the left side as well. And like I said, it had taken 4 to 6 months before I got a definitive diagnosis. And actually, my primary care physician admitted me to the hospital in the psychiatric ward because he had thought that I was going through a nervous breakdown. Starting college, essentially he thought I was being histrionic. And it was the psychiatrist, when I was admitted, who ultimately looked at me and said, no, this is neurologic. This is not psychiatric. Yes. And then got me over to Barnes, where I had met the lovely physician who had diagnosed me and treated me for the first 8 years of my diagnosis. So it was chaotic, very scary. And I guess I can sort of understand why my physician had thought I was being histrionic. I thought I was dying, so of course I'm shaking and bawling and carrying
you were
on
having
because I was
emotional
so
reaction to what was going on, and they saw that instead of the neurological issues.
Exactly. But that experience was what inspired me to go into medicine. And we just hope that I can make a difference in the healthcare system and hopefully never, ever treat someone and not listen and treat someone the way I was treated when I was that scared and sick. So that was my ultimate inspiration for where I'm at now.
That's amazing that you took that, scary, horrible experience and the misdiagnosis there with them, and you took that and you parlayed that into the inspiration for your current career, which is amazing. And now you're helping so many people, and you can now see that, from the patient perspective and the physician perspective. How did your family react when you got that diagnosis?
Oh, so scared, but absolutely supportive. My father would spend hours researching all of the information online and trying to get supplements or diet changes. He was the one that had found, diet changes that might help my disease progression. But he was my rock.
Oh, bless his heart.
During the first. Yeah, and he, God rest his soul, he passed away last summer.
Oh,
but,
I'm so sorry.
He had really helped me accept the diagnosis.
Yeah, it's so important to have that really close care advocate, especially in the beginning. That really helps if we
Mhm.
do have that close care advocate. My mom was that for me, not my husband. My husband, he hated researching things. That was not his forte. But my mom would, she's the one who's like, I'll go to every appointment. I'll look up everything, you know.
Mhm.
So she was that
Yeah.
person for me in the beginning. Now my dad's actually doing that. He's it's kind of flip flopped, and he wants to do that, and he wants to go in every appointment. And I'm like, okay, Dad,
Yeah.
this is awesome because at my stage of progression, I cannot remember everything that I want to communicate to them, even though I try to keep it on my phone. But I cannot always remember everything I am told, at this stage of progression. So it is great to have that person with you. I said, but can you do me one favor? Hey, can you listen at the appointment instead of telling them your West Virginia stories? It's kind of taking up the time if you tell your personal stories during my appointment. He's a character. He likes to tell stories. Now, Dr.
My
Baker, yes, go ahead.
Oh no, I was just going to say my mother and father are also from West Virginia, so
Oh,
I
no,
understand
really?
the pride.
You understand
Yes.
exactly what I'm saying now.
The Appalachian pride. Yes.
Absolutely, 100%. And I'm like, yeah, can we talk more about my lung function with the doctor next time instead of you giving her your biscuit recipe? Can we switch the focus? Now, Dr. Baker, did living with MS give you a unique empathy for your patients who were also diagnosed with MS and other autoimmune diseases?
I believe so, yes. And I believe that my experience with MS has just helped my empathy overall. But definitely when I get a patient in with MS, there's a bonding moment, and I do disclose at that point. If anything, it's every MS experience is different, so that they can see that, here's another perspective
That's true.
on this disease. But I have helped countless individuals with autoimmune diseases get the treatments that they need, make sure that they find a specialist that they can connect with, because that is very important.
Yes, it is.
And give them as much information as I have on complementary and alternative treatments that are necessary when you're struggling with an autoimmune disease.
And that's, I think, something unique about you that many of the members who follow our MS&Me social forums online, they say that they have trouble finding a primary care doctor if they also want to have options for alternative therapies. And for natural therapies, they cannot always find a primary care doctor who not only supports them in their quest for information, but also can provide information about alternative therapy. So I think that is a wonderful combination in your practice.
Trying to follow a trend. Hopefully there will be more providers who are experienced in the alternative sphere of medicine. The awareness is getting there.
Yes, it is. I've seen an increase, an uptick. And it helps that new research has come out that does support the fact that we can control symptoms, through diet, through exercise. Through exercise, we can rebuild damaged neural pathways and give the body a break to heal itself, in some instances and to certain levels. But we also know that science is science as well, and that medicine, traditional medicine, still has its role. And there are cases and there are types of MS and aggressive forms of MS where without traditional medicines to give the body a break and to give it our system, for example, our B cells, a chance to reset, the body's natural healing and remyelination can't take place in all cases. So I like that dichotomy that so many are embracing, all science, natural sciences, traditional medicine, and I really think that is a trend, a good trend, as you say. Hopefully we see more of that. Now, what
Yes.
symptoms were the biggest factor in your early retirement from full-time practice?
I recently went through a new exacerbation of optic neuritis.
Oh,
I had chronic issues with my left eye with
mm-hmm.
central vision loss and distortion of vision, but then my right eye became affected. I recently went through the steroids and then tried plasmapheresis for the
Mm-hmm.
first time, got on a new disease-modifying therapy, Tysabri, but that was the main thing that inspired me to step down from full-time primary care practice in the setting that you normally see. Would I love to open my own practice so that I can template my work, what I need and what I can do? Absolutely. But the way primary care is set up in this country now, I was just not able to keep up.
It's not conducive
vision loss.
to that. It really isn't. And vision loss is the first symptom for many MS patients to even get diagnosed. I know that in my early days, I've had MS and lupus since childhood, so I've had a long history of different symptoms that have either, ended activities in high school or changed my direction in college and hindered my early employment years. But the vision, that is a major one. I've lost total vision twice from optic neuritis because I have it bilaterally when I'm affected, which is, that's unusual. It's usually one eye, but I have it bilaterally, and it's been a real problem for me as well in my work.
Yes, it affects everything.
It really,
everything.
It really does. And I know we had even, in our home, I lost my vision for such a long period of time back in 2002 that we had even moved all of our furniture, in a different configuration so I could make my way through the home. I did everything by touch. I couldn't watch TV anymore. I couldn't read anymore. And we had already been scheduled for an appointment to get me assigned to a seeing eye dog that they were going to train. And we thought it was permanent at that point. It had lasted so long, which is unusual. Usually optic neuritis resolves quicker than that. So I actually had been misdiagnosed that time. They thought that it was central serous retinopathy when I went to the when I went to the eye institute, but it did turn out to be optic neuritis, and it resolved. Not completely. I still had a little loss of central vision and dulled colors after that, but and then I'd lost it again another time. A funny thing that I had a lasting effect from that was I had this fear that if I woke up in a completely dark room that it had happened again. So it had caused this anxiety factor. So from that day forward, I always slept with a nightlight in the room.
Oh.
So if I woke up and saw light, I knew everything was okay, that I could still see, that it wasn't another attack. I don't know why, but for some reason, if I woke up in a completely dark room, my brain just went flight or fight response, oh my gosh, I'm blind again, It really did. It caused anxiety. And my kids are like, why does mommy get to sleep with a nightlight and I don't? They're like, why do you get that? Now, Dr. Baker, what tips would you like to give to patients to make the most out of their appointments with their physicians, any physician's appointment? What do you think the best tips you could give to kind of give them the best experience?
When you know an appointment is coming up, make sure you have some form that you can jot down questions that come up as you go along, starting a couple of weeks before your appointment.
Yes.
I know neurology appointments a lot of times are every 6 months, and there's a lot of stuff that comes and goes during that time, but write it down. And make sure you've got your questions that you want to cover written down so you can go in with your sheet and prepared. Also, take notes during the appointment. I try to go a step further, and as I'm talking with patients, I always have a legal pad there, so I'm jotting down stuff that we're talking about so that I can just hand them that piece of paper and say, this is a Cliff Notes version of what we talked about today.
Oh, that's great. Yeah.
But taking notes so that you can go back and reflect. Don't be afraid to ask questions, because it is our job as providers to answer those questions and to make sure we answer it in a way that you understand every aspect of it. Make sure that you ask about not only the benefits of any treatment, but also the risks, and make sure that information is being told to you. But it's just mainly going in prepared and feeling confident in your ability to be autonomous in your healthcare. You have the ultimate right to make all of your treatment decisions. Yes. And if you ever feel like you're being placed under duress for a treatment, ask the provider why. Why are they so adamant on this treatment, and make them give you an answer. Because that's their job.
It really is.
To counsel you.
And, that's a great tip about the, the risk with treatment, because so often we're even given new medications, even just for some symptom, and we forget completely. We walk out of there and we're like, oh no, what side effects am I going to have with this? I didn't even ask what to look for, And sometimes that you have to rely on your pharmacist, and your doctor, though, knows your complete medical file better. They know you better and what you're more likely to experience, and the cross interactions with what you're already experiencing. But we forget that piece of the puzzle before we walk out. I've done that so many times and went, oh no, I forgot to ask. So that's a good tip.
And a lot of the time, just reading the side effects that you get from the pharmacist in that little sheet stapled to your bag, that'll scare anyone.
It will.
But the physician will have experience with what side effects has he seen in his patients in the past using this medication. So he'll have more practical experience versus the list of 100 different side effects that you might or might not experience.
And another thing that often confuses MS patients, especially with these very powerful medications that we're on, when they go through their 3 phases of trials to get approved, I know here in the U.S., especially for the FDA approval, any side effect experienced, any condition experienced by the patients in the trial, the very large trials sometimes, have to be recorded as side effects of that medication, whether it was directly linked to that medication or not. So quite often you go down through the brochure for the medication that you're given, and you're like, oh my gosh, it causes that. Oh no, oh I can't, oh this risk, oh this sounds worse than the medication, what it's treating itself. But you have to realize, if you talk to your physician, they can give you additional clarity on that, because sometimes, just like, let's just take a DMD, for example. It might say that it has a risk for PML. Actually, there might have been a patient during the trial that it was diagnosed with PML, but it was related to their previous DMD. And there are no cases actually linked in trial and in use to this medication that you're getting ready to start, that your doctor has suggested. Cancers, they might have experienced cancers in line with the general population. A patient in trial might have developed prostate cancer during the course of the trials, yet it has no linkage actually back to the medication itself. But federal law states it has to be listed as a side effect. So talking with your physician can give you a lot of clarity on these scary issues when you're reading about medications online. It really can.
Yes.
Dr. Baker, I've actually referenced your published article, The Use of Cognitive Behavioral Therapy and Mindfulness Techniques in Primary Care for the Management of Chronic Pain. I've actually referenced that before online when we were having discussions with patients. And I wanted to go over just some key points from that and have you give us a little bit of extra information on that, because I think that's a very important piece of work that was published of yours. Some of the key points for you listeners was that chronic pain has become more prevalent than many common chronic illnesses such as heart disease, diabetes, which has led to an increase in prescribing narcotic pain medications and subsequent increase in adverse events and mortality. So, and another point was that using advanced imaging modalities, it has been shown that depression and pain perception activate the same exact areas of the brain. Another point was that chronic pain syndrome occurs in patients who experience pain and disability for a longer period of time than was previously, expected. Another one was that depression and substance abuse are commonly seen concurrently with chronic pain and can be used as a red flag for poor outcomes. And one of the last key points in that was that mindfulness techniques and cognitive behavior therapy can be useful to help patients better manage their chronic pain and increase activity. The reason I wanted to discuss this in particular is we know that there is, the war on drugs. There is a real switch from the use of narcotics, especially for MS patients, because many of them do not understand that nerve pain and a lot of the brain pain, we'll call it, that MS patients experience cannot be treated by narcotics. They need to be treated by different medications. So when an MS patients go to their doctors and they're like, but I hurt, but this hurts and I have MS, so I need a pain medicine. They actually get angry with their doctor and think that they're being mistreated because their doctor suggests that they do not need narcotics. They think that they're being treated like drug seekers, and that's actually not the intention of their doctor. They're trying to get them the proper treatments that will actually resolve the type of pain they're having. And I think as patients, we need to learn to also be very clear about the type of pain that we're having, where the source is. Describe it the best we can to our doctor instead of just saying, but I hurt. But my back hurts. The doctor needs a little more information than that to know exactly what type of pain we're having so they can treat us properly. And I do love that you have actually written so much about using mindfulness and cognitive behavioral therapies to control pain, because I've used that myself. I use mindfulness every day. I'm an advanced patient, MS patient, and I've gotten to the point that I have 24/7 pain that cannot be controlled from my brainstem damage. I have a 24/7 brainstem migraine. I have bilateral TN. We all know trigeminal neuralgia is called the suicide disease for a reason. And I just love that you have highlighted other ways that we can deal with, types of pain that we deal with MS. So I really thank you for writing that. Do you actually recommend mindfulness and the behavioral therapies and all that in your practice to your patients?
Yes, and I've made handouts
Oh,
based
that's
on the same
awesome.
illustrations that I came up with for the book. And there's also a lot of websites out there for free information. Psychologytools.com is one that pops into my head foremost. But I do absolutely recommend these things. Sometimes I'll go through a couple of minutes of the activity with the patient so they understand the rhythm of the breathing, because that's important.
Yes.
And the way to calm those neural pathways that when they become overstimulated, you experience even stronger pain outside of what you should be experiencing normally.
And there's some great research out now that supports exactly what you're talking about, and talking about how MS patients, the type of pain we do have, our normal pain is even actually heightened. We actually feel things to a different level because of that. And there's just some very interesting research to support that right now. And I'm very excited for you to share more of that information with our community over time. I think that's very valuable information. Now, do you find it difficult to actually convince patients of that, though, especially if those alternative methods are new to them, or are most of them very receiving of that?
Um, it's kind of a 50-50
50-50, yeah.
chance
Yeah.
of whether or not they'll be receptive. And
Mm-hmm.
mainly, I think what's gotten me to break through a lot of barriers with patients is I'm persistent.
Yes.
And I'm a stubborn Irish woman, and I will talk about this every time you come into my office. We will discuss this again and again and again and again. And I'll eventually convince people.
Yeah.
But no, I've had a lot of patients just wave it off as one said, trippy hippie nonsense. And
yes.
and they will absolutely off what I have to say. I've had several hostile patients. And I mean, I understand where they're coming from. They've been on these medications. The problem with the narcotic medications predominantly is they've been on them for years,
right,
chronically. And now they're absolutely addicted, whether or not they know it. And people will get hostile when they think that crutch is going away.
Right.
So it takes a lot of patience and a lot of education. And I do tell patients, you know, my role, first and foremost, is educator here. I'm not, you know, my job is to teach you how to manage this.
Yes.
That's my job. And just hopefully that the patience and a kind word will help convince them that the information is coming from a good place. And I'm not out to take away whatever vice they believe is necessary, but I'm actually there to help them.
Yes. And our bodies do, exactly like you said. They will just require more and more and more of the narcotic, even if it's not necessary, you know, to treat the kind of issue we're having. If it was prescribed to us, even in error, our bodies will just crave more and more and more of it to function. So it is a slippery slope. It really is.
And what patients don't, a lot of patients don't realize is that even if you take it exactly like it's written, your instructions on the bottle, you take it exactly as it's written, you are still addicted to that medication.
That's the way it functions in our brains. That's the way it was designed, unfortunately. And there are very valid reasons for some people to be on narcotics. That's not what we're saying. It's a very valid treatment in some cases. It's just that for many of us with MS pain or other autoimmune pain, that's not the correct way to treat it. Actually, it won't even treat it. And there are many neuroimmunologists, MS specialists around the world who are now trying to make that point to their patients that they don't even use narcotics in their practice. At some of the largest MS centers, even here in the U.S., they do not use them. But that's something that maybe another doctor, their primary doctor, might prescribe for another condition. But for MS itself, no, that doesn't treat the type of pain we have with MS. So, yeah, hopefully the word gets out more about that and people will understand why that is the case. Now, Dr. Baker, we just really appreciate you so much for joining our show today. I'm excited to announce that Dr. Baker is joining the volunteer staff here at MS&Me Media, and she will be sharing so much information with you guys in the future. We invite you all to visit our website, www.msandmemedia.com, for more information every day, MS News, personal stories, radio shows, awareness videos, world outreach, our racing division, which is so much fun. We also encourage you to use our hashtag WeHaveMS on your social media to spread the word that if 2.5 million people, their families, friends, worldwide healthcare systems, and employers are impacted by MS, we all are globally. So next week we'll be attending the ACTRIMS conference, so stay tuned for coverage of the 3rd Annual American Committee for Treatment and Research in Multiple Sclerosis. That forum for 2018 is in San Diego this year. So join us next time on MS&Me Interviews here on the MS&Me Radio Network.